All right, future medical billers and coders, it's week 5. So, got a couple coding shots for us, a little more story, a little more juice to squeeze out of our codes. So, as you can see on my screen here, I've got a couple coding scenarios that we're going to walk through, and we're going to code both the CPT and the diagnosis. So I'm going to go ahead and switch my cameras, and I'll be sharing my book during this coding session. All right. Let's get started. Okay, so let's look at question number 1. We have a 52-year-old female that has a mass growing on her right flank for several years. It had finally gotten significantly larger and was beginning to bother her. She was brought to the operating room for a definitive excision. An incision was made directly overlying the mass. The mass was down into the subcutaneous tissue, and the surgeon encountered a well encapsulated lipoma, approximately 4 centimeters. This was excised primarily bluntly with a few attachments divided with electrocautery. All right, so let's get down to the meat of the story. Let's start highlighting our key words. So at this point in the video, you could stop the video, write down your keywords, what you've extracted out of the case, and you could code it, and then you could unpause and come back and check your answers. So at this point, I'm going to start highlighting my keywords, and then we're going to look it up inside of the ICD-10 code and our CPT code. All right, so I I always like to put soft highlights on gender, age. There are certain scenarios where gender and age is going to come into play. Um, Age can sometimes be a factor when it comes to anesthesia. Gender, as we know, can be a factor in our code selection. Um, so in this scenario, I'm just going to put a little light coloring on it just because I don't like to overlook these things because they could come into play. In this scenario, it won't, but again, never overlook those things. All right, so let's see what I got going on next. Oh, she has a mass. Okay, so she's got a mass growing. Where's it growing at? All right, on her right flank. Okay, so that's the next item I'm going to highlight. And this is my location of the problem, okay? The right flank. So where are your flanks? So when you're thinking about, you're looking down at your torso, your flanks are on the sides of your torso, okay? And so this particular mass is on the right side flank or side of her torso. Let's see, what else is an important detail? Okay, what they're going to do. All right, they're going to excise it. So let's go ahead and put this procedure in pink. So now we have an excision. We have a definitive excision. They talk about an incision was made directly overlying the mass. We're not going to code that. We're not even going to color it because that is just the gateway, right, to access the mass. But it is not the procedure itself. It's just the first step in order to access the mass or lipoma. All right, now how deep that mass or lipoma is an important factor. So the mass was down into the subcutaneous tissue. All right, I'm going to highlight that. The surgeon encountered a well-encapsulated lipoma. So visual observation, the patient has a mass. Once they were able to incise and view what that mass was, they've determined it was a lipoma. So now we went from a suspected something suspicious, and that mass could have been malignant. It could be benign, right? So they need to determine what exactly that mass is under the skin. So now we know it's a lipoma. So now we got a problem. I'm going to put my problem in yellow. All right. And how big was this lipoma? 4 centimeters. Another important factor. Running out of colors. All right, so let's just say lipoma was 4 centimeters. The excision was down to the subcutaneous tissue. Location, right flank. There is your basics. That is your keywords for both to determine your ICD-10 code and your CPT code. All right, I got my CPT code book open first, so I'm going to go ahead and start with my procedure. So what do I have? I have an excision of a lipoma on the right flank. All right, so I'm going to go into my index first. I'm going to go to the keyword of excision. So from excision, then I'm going to start looking for that anatomic location. I've already highlighted it here. I found back flank, and then I found the word tumor. So remember how I said tumors can be benign or malignant, okay? So I got a starting point here, 21930, 21933. Okay, that's a good start. Now, I would love to see, just out of curiosity, if I could find anything about a specific term of lipoma, excision lipoma. I took a quick scroll through the other sections of my excision index, and I didn't really find anything else that would have led me to a more specific code set. So again, I'm comfortable here, and I want to start by reviewing 21930 and code 21933. Okay, so now I'm going to head over to my tabular section. Also paying attention once I get over to the specific area that I want to extract my codes from in my tabular section. I also want to pay attention to the subsections, right? So I'm under excision, but what is the anatomic locations that are covered under these particular excision codes? Oh, okay, nice. Back and flank. Awesome. I'm in the right area. So I've already highlighted this, and I can see the one of these suggested codes from my index was 21930. Now, when I come over and look and read 21930, let me see if I can just zoom in just a little bit more for you guys. There we go. There we go. What you can see here is we've got excision, tumor, soft tissue of back or flank, detail, there's our subcutaneous. Now, 21930 is less than 3 centimeters, and ours was approximately 4 centimeters. So all that means is we need to look at our variation or our alternative code. So your alternate codes are always after that semicolon. So remember, this is going to be your parent code up to the semicolon, and then anything after that is a specific type of that service. So 21930 would be for an excision of a tumor. Remember, tumor, mass, lipoma, they can be used interchangeably. Now, the variation, again, same procedure, but greater diameter, 21930. And then it gives you some parenthetical notes. Again, always important to read these. And if they don't apply to you, just move on. So parenthetical note for 21931 says for excision of benign lesions of cutaneous origin, example, a subcutaneous cyst. So cyst is going to be different than a mass or a tumor. So they're simply sharing with you that if you have a cyst, it's going to be found in a different section, and you are going to be in your integumentary codes 11400 through 11406. That doesn't apply to us, but again, always read those parenthetical notes. All right, so final answer for CPT is going to be 21931. All right, so now let's get into our ICD-10 manual. Now we're going to code for the lipoma. So remember, we went from a suspicious mass to a clearly defined condition of lipoma. So I'm going to get into my index and I'm going to go right for that word lipoma. All right, so lipoma puts me on page 341. And I've already highlighted this for us. Lipoma. And then I start looking for my anatomic site. And I found trunk, skin, subcutaneous. D17.1. Fantastic. All right, so now I'm going to go over to my D codes. D codes fall under chapter 2, which is neoplasms. And before I even go over to my code set, I want to read the definition of a neoplasm. So a neo equals new, plasm equals growth, development, formation. This new growth, notice the keywords mass, tumor, can be malignant or benign, which is confirmed by the pathology report. Do not assign a code to a neoplasm until you review the pathology report. Certain CPT codes will specify benign or malignant lesion, so be certain the diagnosis supports the procedure code. All right, so they did not talk about any malignancy. Another thing to keep in mind as you go along through your coding, if your code starts with a C, those are malignant codes, malignant neoplasms. If your codes start with a D, those are going to be your benign neoplasms, okay? Which means they're non-cancerous. All right. So now let's go over and let's check out D17.1. D17.1. First, let's read our category note, good habits. D17, benign lipomatous neoplasm. This is a slow-growing benign tumor, rubbery masses of mature fat cells enclosed in a thin fibrous capsule. Fantastic. That is exactly what our terminology inside of our operative note describes. All right. So D17.1, benign lipomatous neoplasm of skin and subcutaneous tissue of trunk. Detail there, not just the skin, but subcutaneous tissue. All right, so that makes our final answer for this operative report, D17.1. Oops, not 7.1. There we go. All right. Let's look at our next operative report. So a 32-year-old female, let me correct that there. There we go. A 32-year-old female who presented with sacroiliitis. On the physical exam, there was pain on palpitation of the left sacroiliac joint, and fluoroscopic guidance was done for the needle positioning. Then 80 milligrams of Depomedrol and 1 milliliter of bupivacaine at 0.5% was injected into the left sacroiliac joint with a 22 gauge needle. The patient was able to walk from the exam room without difficulty. Follow-up will be as needed. All right, so let's look at this scenario. You can pause if you'd like, pull out and extract your keywords, and then come back to this, unpause your screen or unpause your video and see if our keywords match up. All right, so let's start highlighting here. So again, I always like to do a soft little just in case on, gender, age. So 32-year-old female. Let's see, what's the condition? Sacroiliitis. That is my problem. Going to put those problems in pink. Now, thinking about sacroiliac, what is that, right? So you got to think about where this at is on the body. Well, the sacrum, okay, your sacrum is the lower part of your spine, okay? It's the S spine. That's what we like to term it. And your ilium, okay, is the top part of your pelvis. So your sacroiliac joint is where those two connect at. So the sacroiliac joint connects the sacrum, which is your tailbone or the lower part of your spine, to the top part of the pelvis, which is your ilium. So now you got a little bit better idea of exactly where this joint is. All right, so let's see here. Details, it was the left sacroiliac joint. Okay. So anatomic location. And then what else is important? They included fluoroscopic guidance. So they told us a detail. They're telling us that we did this guidance for needle positioning. All right, you know what? That's an important factor. I'm going to highlight that. And then what do we have? So we have fluoroscopic guidance for the needle positioning, and then we have what was injected. So we have a procedure is injection into the joint. What joint? The specific iliac, sacroiliac joint. Was with a 22 gauge needle. Okay, and then we talk about follow-up as needed. So really, that's it. That's what we need out of this particular scenario. We need to know what the problem was, where exactly that problem or pain was occurring, and what the action was by our provider. So I'm already in my ICD-10 book, so I'm just going to go ahead and start there and start with looking up the term sacroiliitis. I love it. I actually turned right to it. That's fantastic. All right. So sacroiliitis. So if you notice here, you've got sacroiliac joint, and it says see condition. Well, the condition is the patient has sacroiliitis. So we're going to go with that M46.1. Okay, M46.1. So now I'm going to head over. Actually, it'd probably be easier if I did it this way. My M codes are right here. All right. Let's look at our category. Category is M46. They're calling this category other inflammatory spondylopathies. And then M46.1, sacroiliitis not elsewhere classified. That's all we got to go off of. We have one word for the patient's problem, sacroiliitis. So we're going to go ahead and go with M46.1. Okay, and now we can get into our procedure. So we have at the very basic, we got an injection into a joint. Okay, that's your starting point. And then specifically what joint? Your sacroiliac joint. So if you started with the word injection and then you went to joint, you would actually find yourself going in the wrong direction. Take a little more time. You'll find detail, a specific code just for your sacroiliac joint. And it says for arthrography, 27096. So I'm not sure about the arthrography part, but I definitely know that I've got those keywords of injection and sacroiliac joint, and this is a really great place to start. And then I'll read the full code and see if there's any specific instructions or parenthetical notes that lead me elsewhere, because I'm curious about how we're going to code for the fluoroscopic guidance, right? Not every injection requires fluoroscopic guidance. So that's a bonus component. How is that going to be covered? So I'm going to head over and go look at code 27096. All right. So before I even go to my code, again, I always like to just triple check where I'm at inside of my manual as far as anatomic location, because introductions and removals can be done to multiple areas all over your body. So I want to make sure that the codes that I'm applying are specific to the body area. So always in red. Red is going to be your anatomic sites. Blue is all the types of services that can be done to that particular area or subsection. So subsection pelvis or surgery section, musculoskeletal system. What part of the musculoskeletal system? Pelvis and hip joint. Okay. And then introduction. Injections fall under introduction. All right, so I can see once I get over to my tabular section, there's some parenthetical notes that I want to review. So I'm going to start by reading the code itself. 27096, injection procedure for sacroiliac joint, anesthetic/steroid with image guidance, fluoroscopy or CT. Okay, that covers my fluoroscopy. And then notice it says including arthrography when performed. So that was what I was curious about from the indexes. Well, they didn't talk about doing any imaging. So if you've got graphy, that would be the arthrography would be an image, right, of that joint. But they didn't do that. They just used fluoroscopy for the needle positioning. So what you'll want to do is read your parenthetical notes. It gives you more confirmation or affirmation that you're on the right track, but it's telling you some very specific details. It says 27096 is to be used only with CT or fluoroscopic imaging confirmation of intra-articular needle positioning. So if you weren't sure before, now this is really nailing it down. And it also gives you some additional details, some more guidance. It says, hey, if there was no fluoroscopy imaging performed, then don't use this code. You got to go over and use 20552. And then it also gives you the details. It says, by the way, this is a unilateral procedure, one side. For bilateral, use modifier 50. So the fact that it told us that this was a left joint, okay, that came into play, okay, because that means it's on one side, unilateral. Fantastic. So that's what I needed to know. So 27096. All right, last one. All right. An infant with genovalgum was brought to the operating room to have a bilateral medial distal femur hemiepiphysiodesis done. Woo! On each knee, the C-arm was used to localize the growth plate. With the growth plate localized, an incision was made medially on both sides. This was taken down to the fascia, which was opened. The periosteum was not opened. The orthofix figure of 8 plate was placed and checked with X-ray. We then irrigated and closed the medial fascia with 0 vicryl suture. The skin was closed with 2O vicryl and 3O monocryl. All right, so problem, procedure. Let's figure it out. So some key things here. So the fact that they're telling us that this is an infant, this is an important factor. This doesn't tell me age. However, if we're talking about an infant with a condition, this is not acquired. This is going to fall under your congenital category, okay? So let me actually put problem in pink. And in this scenario, infant is a very important factor. Okay, so now we got a baby that has a condition. They were brought to the operating room. Okay, and here's the service. Keywords here: bilateral, medial distal, femur, and then hemi. Hemi is half, okay? So now we have a hemi epiphysiodesis. All right, so I'm going to put pink for my procedure. So a lot of this is detailed: bilateral, medial, distal. Now, femur is important, but hemiepiphysiodesis is the procedure. And then those bilateral, medial, distal, and the location are those add-on keywords or supplemental words that are going to help guide us to the exact type of service to code. Let's see, what else is important here? On each knee, the C-arm was used to localize growth plate. Maybe how far this was taken down. Periosteum was not opened. The orthofix figure of 8 plate was placed and checked with X-ray. You know, I'm going to highlight this as well. This may come into play, a figure of 8 plate, and the fact that it was checked with X-ray. That's probably just the way that the service is performed, checked with an X-ray, but I'm not 100%. I don't want to leave that out and overlook something. Again, some codes or some services may be performed with or without this service, or just like in our last example, where injection procedures are not always done with fluoroscopy or CT. So just want to add this in here, and if not, we're going to end up just removing that highlight if it isn't a necessary component. All right, so I'm already inside of my CPT manual, so I'm going to go ahead and start there. And I was thinking, and I'm going to go ahead and go through this. I was thinking about the word hemi versus the word epiphysiodesis. So when I went over to hemi, I didn't find anything that was representative of hemiepiphysiodesis. Now, I did see hemiepiphyseal arrest, but it was for the elbow. And this was, in our scenario, they talk about the femur. So I'm like, I'm not 100%. And this is not the right anatomic site. So I thought to myself, okay, what if I remove the word hemi out of the equation and just focus on the word epiphysidesis and then start from there? So I went to the word epiphysiodesis. And then look at that common thread that we found in our first index search. C epiphyseal arrest. All right. So now we're guided back over to that word epiphyseal arrest. So again, took us on a little journey, and that's great. That's fine. So now we've got some options here. Specific locations. We got femur, fibula, radius, tibia, ulna. They made it clear inside of the report that this is bilateral medial distal femur hemiepiphysiodesis. Perfect. So now I've got a starting point. Now, the first thing I do when I look and I see when I have a lot of codes to choose from, I think to myself, okay, what are some common threads? And I notice that 20150 shows up in every single one of these anatomic sites for the same service. Okay. And then I start to look and say to myself, okay, so what's going to be, what is the common thread with this 20150? And then what is going to be the differences? What makes each one of these other code categories unique? Another thing that I like to point out here is that this is what I would call my rogue code. Okay. Why do I want to call it my rogue code? Well, it starts with a 20, and all the other codes in my code options under femur start with a 27. So I kind of want to just eliminate this row code, or maybe it's the code to choose. I don't really think so, because this code is included in every single one of these anatomic sites. And I think we're going to have to get a little more specific, but this is how you grow in your coding. Just process of elimination, right? So out of curiosity, I want to go over and see what 20105 is and why I would not choose it. Just as important. 20150 talks about an excision. Okay, and that is definitely not what we did. Now, it talks about excision. It's got that word epiphyseal, but it has nothing to do with, we don't have a with or without soft tissue graft. And it's just not fitting. And notice also your subsection. This particular code is under general, and I think we can get a little more specific. So I would go back, or I would have my scrap paper so I wouldn't have to go back, and I would have my codes already ready for myself. And then I would start to look and see, okay, what else do we have in, what else would be a rogue code? Well, I also noticed that 271 versus 274, 274. Okay, so the next code that is potentially an option would be a 27185. All right, so let's go check out what 27185 is. 27185. All right. Now I found 27185, but I also need to triple check my anatomic location that this code is coming from. So pelvis and hip joint. Now remember, they talked about the femur. Now it says including head and neck of femur, and you're like, okay, well, maybe, but pay attention to those key words we highlighted. We highlighted the keyword of medial distal femur. That is different from the head and neck of the femur. So top of the femur bone, it would be the head and neck. Distal is going to be further down. So although this subsection does include parts of the femur, it's not the distal part of the femur. And that's an important component for us. So while that felt good, right? Again, this is why another reason why I wanted to do this video and to demonstrate that we just don't want to go directly and just go right to the code. Get familiar with your book. Look to see where exactly that code is being, what body section, right? Like bones, hip, joints, head, neck, and femur, is that particular code associated with. So right away, I'm not feeling good about this code because it's not coming from the specific anatomic location on the femur that we need to account for. Okay, so I'm putting a soft no on that one. So now I tell myself, okay, well, what else do I got to choose from? I got a 27485, and then I noticed that I have a lot of codes that are in that family that have been recommended to me in that 274 category. Cool. Then I'm going to head on over there and go to 27475 and see what I find. All right, 27475. Okay. Arrest, epiphyseal, any method, example, epiphysiodesis, distal femur. Okay, I'm feeling it. Now remember, we want to go back and we want to just triple check what subsection these particular codes are coming from. Okay, femur thigh region. Okay, so again, now we're talking about the distal part, the distal part and knee joint. So your femur bone is a pretty long leg bone, right? So it goes from the top of where your hip is all the way down and connects to where your knee joint is. So it tells us it includes the tibial plateau. Fantastic. This is important though. This is what I need. Femur thigh region. That is your distal femur. Now that we've confirmed that, okay, now we're coming back over here. This subsection where these codes are found come from the repair, revision, and reconstruction subcategory. Fantastic. Now, 27475 feels pretty good, but can I get any more detail? And then what am I missing? I'm missing that word hemi, right? So close, but not smoking, right? We're warm, but we're not hot. So what else could we find? Okay, well, I had a range of codes that was supplied to me from my index. So I'm going to go, these were all the codes that were included in that range. So what else do I have? So remember this, if the parent code, right, doesn't fit, then the indented codes underneath of it don't fit as well because they have a parent-child relationship. So remember, anything past that semicolon is a variation of that base service. So 27477 and 27479 would not, I'm not even going to look at them because they're associated to that parent code. But here comes 27485. There's my hemi. Arrest, hemiepiphyseal, fantastic. Distal femur or proximal tibia, could have been either one of those, or fibula. And then it says, example, genovarus or genovalgus. I love it when a plan comes together. So they not only gave us all those details, they also gave us conditions that this particular procedure would treat. So your final answer for question 3 is going to be 27485. All right, now let's get our ICD-10 code. So remember, we talked about the fact that they told us it was an infant, so we know that this is going to be the baby was born with this. So we call these congenital conditions. Congenital conditions fall under a category or a chapter inside of your ICD-10 manual of Q codes. So congenital codes start with the letter Q. All right, so now I'm going to start looking through and start looking for that word genu, valgum, valgus. What do I have here? Genu valgum. Ah, there we go. So I found the word genu, okay? Now I found congenital, but I want to find that word valgum. There it is. And then look what you got there. You've got two options. So again, this goes back to highlighting that word for infant. So we know this wasn't acquired. We know this is a genu valgum congenital. They don't need to they don't have to specifically tell you it's congenital. When they tell you a baby is brought into the operating room for a condition and you find in your index, you've got two options for that condition. Was it acquired or was it congenital? Remember, if we're talking about infants, we're referring to these as congenitals. So Q74.1. All right, let's take a little journey over to our Q codes. Probably easier for me to work this way since it's towards the back. Awesome. There we are. Q74. Let's make sure to always read our excludes notes or any additional instructional notes. And again, remember that if they don't apply to you, move on. But always make sure you're reading your instructional notes that come with it. They're included in the category you're selecting your final answer from. So we see that there's a stop sign, so we know that's not enough information. So we're always going to look for the one that gives us the highest amount of detail. So let's see what this excludes note says. Excludes one. Remember what an excludes one means. Excludes one means that any code that's included in that note, excludes one is an instructional note, is not coded here. Your patient cannot have one of these conditions in this category and have one of these following conditions. So it's excluded. These conditions are excluded from the Q74 category. So it's simply just saying if your patient has polydactyl, reduction defect, syndactyl, go over and look in this other code category. Again, if the note doesn't apply to you, just move on. Q74.1. Now we're talking about congenital malformations of the knee. Congenital absence of patella, and then also notice, before I start reading these are all other variations of conditions that will still fall under the code Q74.1. So they could have said that it was a congenital malformation of the knee. They could have said that it was a congenital absence of the patella. They could have said it was a congenital dislocation. They could have diagnosed a patient with congenital genovalgum, congenital genovarum, or rudimentary patella. All of those still fall under the code description Q74.1. Notice this, Q74.1 has its own excludes note. It says it excludes congenital dislocation of the knee. So remember, excludes one means that your patient cannot have Q68.2 and Q74.1 is basically what it's telling you. So if it's a congenital dislocation of the knee, remember your knee is a joint. The patella is like a bony covering, okay, on the knee. So a little bit different. They're telling you, hey, if this is a knee congenital dislocation, go over and see Q68.2. Q68.2 for geno recurvatum, and then nail patella syndrome. Okay, so again, if none of that is mentioned inside the operative note, then just bypass that excludes note, but never overlook reading it. Okay, so here's our congenital genu valgum, Q74.1. Q74.1. All right. I hope you found these fun. Kind of just wrapping up our our term here as we're entering into the last, how many days we got left here? 1, 2, 3, 4, 5, 6. We've got about 10 days left. All right. So I hope this was helpful. And if you have any questions, always reach out. I'm here to support. And I will see you and you will see me in the next episode. All right. Have a great day.